for it.
Okay, hi. Hi, Alicia. I'm Deana Mercier. I'm a physiotherapist. I've been working in pediatrics for 20 plus years. I also work with adults, but most of my years of practice have been in pediatrics. And I have developed somewhat of a passion for the interest around toe walking in children. And it led me to do quite a bit of research on the pattern of toe walking in children. And so taken some courses and I've collected some data on a number of children and looked at orthotics and various bracing techniques as well with children. And so tonight's talk was really just to share my knowledge and my experience. I would love to hear from everyone, their knowledge and experience, and hopefully we'll have a good discussion tonight. Well, of course, my arrow is not going to work when I go to use it. There we go. So we're really talking about toe walking being a toe-to-toe gait, where the rest of the foot is not in contact with the ground during the full gait cycle. So it looks pretty much like this picture, toe to toe. However, this picture is quite an extreme representation of how high the heels are off the ground. So I just wanted to point out that those heels could be quite low to the ground and still be considered a toe walker. The group that we're talking about tonight are the idiopathic toe walking group. Those are kids that for some reason are walking on their toes, but we don't know what the cause is. It just sort of happens spontaneously. It could happen when they start to pull to stand and they're up on their toes, or it could happen later when they're already cruising around furniture and all of a sudden a parent or caregiver notices them go up onto their toes. And this group of children are not inclusive of those children who have a neurological condition. So it's really important for the diagnosis to rule out any other neurological cause of toe walking. Those are the group of kids that maybe have high tone issues, like kids with cerebral palsy. Usually it's a neurologist or a developmental pediatrician that will assess those children and rule those kids out as to not being what we call idiopathic toe walkers. So tonight I'm really just going to focus on the idiopathic toe walkers. I also wanted to take this time to point out the importance of us understanding gait in terms of how gait or how walking pattern develops, and that the literature tells us that there is no normal variant of early gait pattern of toe walking. And what that means is when you see toe walking, it is not a normal development of gait. So it tells you that there's something going on that is making that child go up on their toes. It's not a typical pattern that we see in gait development, okay? So if we were to look at a chart of the gait cycle, and I didn't want this to get very complex, but I wanted to point out that the gait cycle is made up of two phases. There's the stance phase, which are the first 5 pictures from the left going to the right. That means that at least one foot is in contact with the ground. And then the last 3 pictures are showing the swing phase. So when you look at normal gait, at the beginning of the cycle, you'll see a heel strike. So the foot needs to be up off the floor and the heel is only contacting the ground. And then there's a weight transfer onto that leg until it's pre-swing. And that's when the child goes up onto their toes to push off, bend the knee, and bring that leg to swing through to start the gait cycle again. Okay, so I just wanted to show just a very simple process of gait through the stance and swing phase. Child development of gait, we should generally see a heel strike by 18 months of age. That doesn't mean that the child's walking on their toes up until 18 months. It's just more of a flat foot gait, or there's quite variability in where they're putting their weight on their foot. But if they're walking by 12 months of age, that gives them about 6 months of age to practice weight bearing on their feet, shifting their weight on their feet, and actually practicing taking steps. And so by 18 months of age, it's quite common for us to see a nice heel on the ground. by 3 years of age, we should see more of heel hitting the ground and then toe pushing off. And it's not until 7 or 8 years of age we see a more adult type gait. So it takes many years to develop a normal, typical gait pattern. What we don't know about idiopathic toe walkers is what causes them to walk on their toes. So often when I ask some of my questions to the caregiver, the parents, is there is a strong connection family-wise. So usually mom or dad or somebody in the family is also a toe walker. So the literature is telling us that there might be a bit of a genetic component to it, but we're not really quite sure what's causing this group of kids that we call idiopathic toe walking. After many years of me observing lots of kids, I don't like to put people into categories or put kids into categories, but I would be a little cautious, but comfortable in still saying that there's sort of two groups I look at. After I do my assessment, I'm confident in saying this child sort of fits in the biomechanical issue, where there's an issue with the structure or the position of the bones and muscles and how the child is moving their body. That's what I call a biomechanical. The other group of kids are toe walking more so because of sensory issues. And those are kids that are more seeking more sensory input, or they're actually trying to avoid it. And there are several groups of kids that are associated with toe walking that I wanted to point out. So if you have a child that is delayed in motor development, you might see them when they reach the stage of standing, you'll see them up on their toes. Children who are born premature or have low birth weight often will be toe walkers. Some children I see later in life have a huge growth spurt all of a sudden, and they've lost a tremendous amount of range, and that's when I see them, so rapid growth. And then there's a group of kids that are in the autism spectrum category that when they get excited, it's more of a sensory or firing of the nervous system, and that tends to make them go up on their toes. When I look at the kids that from a biomechanical point of view, the issue is lack of stability at the foot. So they pull to stand and they realize that their foot is not a good firm foundation. And when it's not a firm foundation, solid foundation, they cannot start to practice appropriate movement patterns. So whether it's just standing and playing at the couch or taking side steps, if they feel that foot is unstable, they can't already just start to do those normal movements that they need to do on their feet. And also, they are not using the muscles the way they're designed to be used. And so that activation of muscles or function or use of their muscles doesn't happen. And so we start to see later on with continued toe walking, we start to see length issues, strength issues, all those kind of things. It's like as adults, when we go to the gym, we lift weights and we get stronger. Well, children need to do a typical or normal gait movement in order to strengthen all those muscles in their legs. And when they're toe walking, that's not what happens. The other group of kids, and I don't want to spend a lot of time on the sensory issue kids, but those are kids that are driven up on their toes generally in response to the environment. So as I mentioned before, they're either seeking input, so they want more sensory input from that foot, or they're trying to avoid input to the foot. And as I mentioned, those kids can have another diagnosis of autism. And it's really important to include some sensory strategies along with all the other therapeutic treatment options that we offer. The other thing is during the assessment, we need to look at screening vestibular issues, visual, proprioceptive, and motor planning issues. Why is toe walking such a big deal? I've met lots of kids over 20 years that walk on their toes, that participate in sports, that go to school, do everything that they want to do in their day. My information back to the parents is the concern would be the impact on bone development. Our foot is not designed to bear weight on the toes. And with excessive abnormal forces through the foot, going up the chain, so that means through the knee joint, through the hip joint, up the back, can lead to abnormal bone development. And we've seen that in some of the literature now, where the ankle bone, for example, doesn't develop properly because of the forces in the wrong spots. So it's really important that we get these children off their toes and practicing a normal gait as soon as possible. There's orthopedic issues over a long-term abnormal use of joints. We all know what happens is osteoarthritis, and that could be at the ankle, the knees, hips, and back. Then, of course, as I mentioned before, we can end up with short muscles or long muscles, short, weak muscles or long, weak muscles. And so strength issues become a concern as well. Most of the time, the reasons or the problems of falls all the time is what brings children in to come for me to see these children, is there's frequent falling. And then not to forget the impact on poor efficiency of gait. And so the other information I get from parents around their child's function is they complain of aches in their legs, pain in their legs. They complain that they can't walk anymore. They fatigue quickly. And if left unchecked, they can become sedentary individuals because it's too much work for them to keep walking on their toes. Our overall goal is to not think that we can change the toe walking, okay? So once a toe walker, always a toe walker. The literature that has been done up to date goes back probably, I don't know, 25, 30 years now. And no matter what treatment has been offered, we have realized now that there's a constant drive message from the brain telling that child to stay up on their toes in most cases. And so I don't go in thinking I'm going to change the child to be from a toe walker to not a toe walker. What I go in is teaching parents and caregivers how to help their child practice a normal gait pattern, perform it as much as they can, do some stretching, some strengthening, and some functional activities that help achieve all that strength and length that they need to get. But every time they go through a growth spurt, we run the risk of losing length again. So I say here, it's through the growing years, a long haul. It doesn't mean that they have to have physiotherapy once a week till they're 18 years of age. That would be great for me, because then I'd have lots of kids come and see me. But it's really about you having the knowledge as a parent or caregiver to know what to do at what point in time, and having that knowledge and those skills that you could manage it on your own. And you only come in to see the physiotherapist when there's a change needed or something different needs to be added. Our assessment is quite detailed and quite lengthy, and I may not finish it all in the first session. It might take me 2 or 3 sessions depending on what I'm looking at. But I just gave you a little bit of a list to show that I do a big history taking of the toe walking. When did they start toe walking? Did they go up on their toes right away? Did they walk for a while, then start to go up on their toes? What percentage of time are they on their toes? Is it 50% of the time? So sometimes up on their toes, sometimes flat foot. I'll do a full passive range of motion. That means taking all their joints, ankle, knee, hip, all the way up, and looking how much I can move their joints. And then I'll ask them to actively move those joints. So how far can they lift their foot up? How much can they bend their knee? How much can they bend their hip? So I get an idea strength-wise and function-wise, how much can they move on their own? And has it changed that normal movement pattern? Looking at strength at all the muscles, even up into the core. I look at abdominals and back, right down to the feet. We look at motor skills, so it might be things like standing on one foot, hopping on one foot, sidestepping, of course, gait. And gait I will analyze front view, side view, back view. I'll do a thorough assessment of tone just to make sure that there's no tone issues. If there's high tone, then we need to keep an eye on that, because that tends to drive the foot more up onto their toes, and I need to be aware of that. But on the flip side, there's some kids that have low tone in their trunk, and when you have a low trunk tone, you don't feel stable, so you might go up on your toes to try to create more stability. So some of those kids who have low trunk tone are toe walkers. Or I have some kids who have hypermobility of their ankle joint, so that extra movement that happens in those joints cause them to go up on their toes. And then, of course, I'll look at a sensory profile, but often I rely on the occupational therapist to look at sensory issues. But there's some really simple questionnaires out there that's easy to gather that kind of information from the parents or the caregivers to get an idea if there's also a sensory component. So there can be some kids that have biomechanical and sensory together. So looking at length, I'll do a thorough assessment of how much can I move that foot by dorsiflexing the toes, so that's lifting the toes up. And I do a R1 and R2, and I don't want to get really into depth with this, but I just wanted to point out that there's 2 measurements I take to tell me what that muscle is doing. And that R1 is resistance 1, so that's when I move the foot really quickly, I get a catch from the muscle, I want to measure the angle of that foot at R1, and then I move that foot any further I can get to a full big stretch, that's my resistance 2. Those 2 numbers are really important to me to help guide my treatment. Length is not the only thing that we should treat, it's just the beginning. If there's loss of range, it needs to be addressed initially, right away. If there's only a little bit of loss of range, it helps guide me to go in a different direction. So this is what we're looking at in terms of the position of the foot. So I want to know how much I can dorsiflex that foot up, because that position is very important for gait. Here's an example, a chart of various ages. So if your little one is 12 months to 24 months of age, they have the most available range to them at the ankle, 35 degrees. Going into later years, you see that we lose 5 degrees sort of for each grouping of age. And that's really just because of the fascia tissue, the muscle, the change in our muscle tissue in terms of elastin. And so as we get older into adulthood, we don't have that 35 degrees of range available to us at the ankle. Okay. Here's some of the important muscles that we need to look at when you're a toe walker. We want to make sure we're strengthening the gastrocs and the soleus. So the picture on the right shows you the 2 calf muscles, and they join together at the Achilles tendon and anchor it to the heel bone. So if I have a child that has a good amount of range of motion at that ankle, I will get them to do some heel raises, for example, to start strengthening that calf muscle. The muscle on the left is the opposite muscle. It's on the front of the shin. It's called tibialis anterior. That muscle lifts your foot up so you can have a heel strike at the beginning of the gait cycle. Its job is to lower the foot down so you can put weight on that foot. So it's really a crucial muscle in controlling that foot position through the gait cycle. Both muscles need to work together. Both muscles need to be taught how to work together. And when you're a toe walker, you're not really using either muscle through any part of their range of motion. They both stay contracted and they're not really moving because that ankle joint is not moving. The other key muscles are further up, the hip, the pelvis area. So if you're not doing proper step length, you're not strengthening your butt muscles. That's 3 muscle groups, the small, medium, and large. And those all 3 need to be strengthened, and they need to be taught how to propel our body in space. They're the ones you use in conjunction with your calf muscles to propel yourself to walk. When you don't have strength in those muscles, what a child does that's a toe walker is they actually lean their trunk forward because they don't have the propulsion. So they lean their trunk forward as if they're falling, and that's what allows them to progress. What happens though is they get this increased curve in their lower back, and they get weak hip flexors and weak abdominal muscles. And that's why on the left I've shown you that it leads to me to teach them how to strengthen all those muscle groups in your abdominals. And there's lots of different muscle groups in the abdominals, not just one. We can't forget the rectus. This is the front of the thigh. That muscle is important during stance and swing phase, and it's important to teach that muscle how to contract and when to move through the gait cycle. When you're a toe walker, the child tends to lock their knees up, so they're contracting their quad muscle, and they're keeping it contracted because they're keeping the knee locked. And so as they're stepping, they're kind of just falling forward and moving that leg forward really with the pelvic muscles, which is the hip flexors and the butt muscles, and not using so much of the quad muscles in the front thigh. So once I get the child to practice normal gait, I got to get them to do that knee bending so that they are using the quad muscle through the gait cycle. So just to reiterate, there generally needs to be strengthening to the weakened muscles, tibialis anterior, that's the one in the front of the shin, the calf muscles in the back of the lower leg, the hip extensors are the butt muscles, the quadriceps are the muscles in the front of the thigh, and the abdominals include the rectus, the transverse, and the obliques. The key really is then coordinating those two muscle groups, the belly and the butt muscles is what we say, to help give them stability in the trunk and to help use those muscles for gait, for walking. And not to forget, the really important thing is teaching the child about putting weight on their heels. So I do a lot of educating and teaching various activities that they can do where they're getting their weight back on their heels. So just to go through my assessment again, we talked about range, strength, motor skills, their gait, tone, various joints and the stability of the joints, and sensory. Not to neglect this is a really key part of therapy. Physiotherapists generally in Canada, I think it's fair to say, Kristen, don't make orthotics. We have the fortunate experience of having orthotists who are specialists to make special devices for our feet. So often I partner with an orthotist when I have an assessment, I'm finished my assessment, and I think that the child needs some type of structure on their foot to help give stability, I will do a joint visit with an orthotist. It might lead us to decide a custom orthotic, which is just a solid plastic piece under the foot. It might lead me to decide that we need a supramalleolar orthosis, which comes up the side of the ankle and stops at the ankle bones. Or it might be a brace that has to go up the whole leg, but stop a few inches from the knee joint, which is called the ankle foot orthoses. Those braces can either be hinged, where the foot plate can actually move with the foot, or it stays solid so you can't move. It's a nice solid brace, but it's flexible so it can flex here as the child loads the brace. We also have nighttime stretching orthoses, which kind of are a piece of plastic up the back of the leg and underneath the foot, and it has Velcro straps, and that child will wear that often with a knee immobilizer or a gaiter to help keep the knee straight, and that helps to provide a stretch while the child is sleeping. So that paired together generally is used for nighttime if we need to get more stretching. About 15 years ago, there was research that told us that if we can somehow stretch those muscles for greater than 6 hours, we can see a change in length. And so that technique had been introduced many years ago because of that literature. It's helpful, but I find the more helpful is when the child's up on their feet and being active. So it's all that active range of motion that I see better results, but both are important. So just to recap, intervention or treatment really is very individualized, and it's not until the therapist finishes the full assessment, gets a really good idea of what's happening and what's the first thing to do and what's to do after, and to set up a plan. And it's really about those follow-up appointments where I might change my treatment approach depending on what the child is doing. If they've had another growth spurt, if they've gotten stronger, it helps guide my treatment. I also have some other modalities available to me, like muscle electrical stim, where you can put little electrodes on the muscle, and in a very gentle way, it helps to stimulate the muscle to help it to contract. So I might use that for some muscle groups. Or I can use kinesio tape. I think most people know what kinesio tape is nowadays. I can put that on the butt muscles, the belly muscles, the tib anterior. I can put it anywhere on the body if I want to help facilitate the child to contract a muscle. And I always say to parents, last resort is a referral to surgery, to an orthopedic surgeon, because in most cases I see our conservative management by physio is effective. It generally is most effective the earlier we get the child. So the earlier I see the child, the more success we have. If I see a child at 9 years of age, for example, and they've lost 30 degrees of range of motion, those children tend to not do as well. I can't get them to the same point a year or 2 years from that point, as opposed to if I saw that child toe walking at 2, 3 years of age. Okay? So at this point, it's your turn to take the first step and ask questions and give me comments. And yeah, let me know what you think and what your thoughts are.
Thanks very much, Deana. I have a question if W sitting is connected to toe walking.
That's a great question, Alicia. W sitting tells me that the child is looking for stability. They're trying to widen their base of support while being on their bum. It wouldn't be surprising to me to see that child when they stand up, that they go up on their tippy toes and maybe turn their feet out, or they stand up and they turn their feet out, because that's just another sign that they're looking for stability. And the other concern I have about W sitting is, let's say the child was W sitting very early on, because children can start sitting by 6 months of age. If they're W sitting because they're lacking stability in their weak trunk, and they already start their hip muscles at an advantage in terms of length and strength. So W sitting, what happens with the muscles is it causes the internal muscles, internal hip rotators, to become short and weak. And on the reverse side is it causes the external hip muscles to become long and weak. So that can then lead to a child toe walking, because now they have an imbalance at the hip, and it leads them to toe walk because they're still searching for stability. Does that make sense? I think we lost Alicia.
Here she comes. She's coming back.
So sorry about that.
Did I scare you away, Alicia?
No, sorry. Okay, so the last thing I heard was it becomes short and weak.
So W sitting may not directly cause toe walking, but it could, because the W sitting tells me there's a lack of stability in the trunk. So maybe the child chooses to do that because they're trying to figure out how to sit independently. So if that child then gets to the point where they're pulling to stand, it wouldn't be surprising for me to see them go up on their toes or turn their feet out, because they're still looking for stability. And it may be because of the weak trunk. My other concern, though, is they do that, but they're not going to stand on their toes because of the W sitting, but because they sat in W sitting for so long, they now cause an imbalance in the muscles at the hip. So they now have short, tight internal hip rotators and weak, and then they also have long external hip rotators that are weak. So when the hip internal and external rotator muscles are weak, you don't have great stability at your pelvis. So you might stand up on your tippy toes to try and lock those joints to get more stability. Does that make sense?
It does. Thanks very much. Sorry, I missed the beginning. Are you at Blueberry Therapy?
I'm at Blueberry Therapy, yeah. Right
Okay.
now I'm booking, help me out, Christine, Tuesdays and Thursdays. And I do I'm still doing virtual visits in the morning, and I've got some booking available in the afternoon if you want face-to-face at the center. But I'm pretty flexible too. I can switch either around, just depends on what's happening. But right now, Tuesdays and Thursdays.
Okay, great. And I can just book through the website?
Yeah.
Yep.
Yeah, I think the best thing is I'm going to bring my son in to see you. He's turning 3 next month. He's been, I can't even say how long he's been toe walking. I'm going to need to kind of really sit down and try to like think back. I also sort of make some notes like developmentally for him to see if I've made any notes about that. yeah, so I'm going to make an appointment with you to get that looked at. He has some sensory stuff too. So it'll be interesting to see your assessment about whether it's the bio or the sensory or a combo of both.
Right, it could be both, yeah. Yeah. So is he the one W sitting?
He is, yeah.
Yes, yeah, okay.
And that just started, but whenever I catch it, I um I just verbally tell him toes forward. But when he was in daycare, I don't know, if they corrected that. So I'm
Right,
sure there have been times where he's been seated like that for quite a bit.
yeah. Yeah, it's one thing for me to say, don't let them do this, right? But in your day-to-day, and you're not always with them, it's a completely different ball game in trying to figure out how do you keep them at a W when he has found that works for him. So you can't take it away from him, but you have to give him something else better that's better for him. So now that he's 3, do you have a little table and chairs, and maybe some of the activities you start to do sitting on a chair where his feet are supported, his thighs are supported, and he uses a table to play. And then that helps you get him out of that W position.
Yeah, we do. That's a great idea.
Mhm. Yeah, it's actually a little bit easier to get them out of W once they start to get older, because you can start to do more table sitting activities, and they're not doing as much play on the floor activities. The hardest part is if everything he's doing on the floor, he wants to play on the floor, it's really hard to stop that habit once they've started.
I was going to say, Deana, having worked with kids for you know, a number of years.
Not as long as me.
That's right. You're way older. I actually didn't realize that, more normative gait pattern didn't come until like 7 or so.
Yeah, you're more a mature adult gait pattern where the timing of the muscles, the rhythm, the step lengths, all that kind of stuff, it takes that many years to practice an ideal gait. It's quite amazing, isn't it?
Yeah, that is quite amazing. And I have another child that I was seeing at a school. I think I'm going to have to refer you to. Who,
Great.
yeah, specifically for all of this stuff.
Well, until recently and until seeing this topic, I didn't really think of toe walking as like a problem that needed attention. So I'm so glad that I stumbled upon this webinar, because now I know that we need to get him assessed.
Yeah, and the earlier the better. I feel like the message is not out there, and it's not just for the parents, it's also for the family doctors. Because I've had so many parents bring 9-year-olds. For some reason, it's not the parent's fault, right? The parent has been told for many years by their family doctor, oh, toe walking is normal. He'll outgrow it. She'll outgrow it. And life goes on. We get busy, right? And I think we get almost not complacent. We get used to our child moving the way they are, because children can figure things out quickly. Like I said, I've met lots of kids who can walk on their toes and do everything and not have a problem until later. And then they start to have all these other problems. But I think it's really important that we continue to give the message to family doctors that if you see a child toe walking, if a parent brings it up, saying, hey, my child's up on their toes, it doesn't hurt to send them to a physiotherapist for at least one consult. And often it's me giving education to the parents about what's going on and what you can do to change things. It's not a lot of hands-on by a physio. It's really more about knowledge acquisition for the parents. And so I don't believe, I still get a little bit upset when I hear doctors say, oh, don't worry, they'll outgrow it by the time that they're 3. Well, most kids do, but then there's some that have chosen this strategy, it's working for them, and they can't stop doing it. So the sooner you see the physiotherapist, then the greater chance that they haven't developed a habit and they haven't started to run into those things that are harder to change.
I really appreciate that comment. And I've always felt, especially I have a second child now, but with the first, you go see the doctor every 3 months, up to 18 months. And then after that, you're sort of done. And I always felt like, okay, that's it. Like no one's checking in anymore. It's solely my job to keep an eye on all these things. And what about the things I don't know about?
Yeah. Well, call your friendly Blueberry Therapy Center and just ask those questions. Right? If we don't know the answer, we'll find the answer for you.
I think that's true. And honestly, I think it goes for not just toe walking, but many other things that you go to a doctor with. Like my child isn't even a year yet and only poops every once a week.
Yeah.
Doctors often say, oh, well, their GI system is developing, it will work its way out. And sometimes I see parents, you know, with kids who are 9, 10, 16 and say, you know, this started before they were even a year and we identified it, but we're kind of dissuaded from thinking that it was much of an issue. So yeah, I think there's lots of education about how to do things in a preventative way versus waiting till it becomes a problem.
Definitely. I wanted to thank you so much for still running the session, even though I was the only participant. And I'm definitely going to get on the website and book an appointment with you. I look forward to meeting you in person.
Thank you, Alicia. I'm glad you came tonight.
Yeah, so glad you came, Alicia. Was there anything else you wanted to say in kind of wrap up, Deana, or?
I don't think so. I think I said everything I wanted to say.
Okay, great. Yeah. Thank you very much. That was awesome, and thank you for letting us record it, because I bet we will have people that want the information at a later date.
I was just going to say.
Yeah, I'm wondering if you're willing to share